Hello and welcome to the Model Law Knowledge Lab Treatment in Emergency Department Settings. Good to see you all. I am Becky Rose, Senior Director at Ruler Strategies, and I am part of the team supporting the Legislative Analysis and Public Policy Association, otherwise known as LAPA, to bring you this Knowledge Lab today. I am joined by my colleague, Tara Kunkel, Executive Director at Ruler Strategies, who will interact in the chat throughout the discussion today. So, what are knowledge labs? These are virtual learning series that provide stakeholders with an opportunity to deepen their awareness and understanding of how model laws can assist jurisdictions in addressing substance use disorders. The knowledge labs are made possible by a grant from White House Office of National Drug Control Policy, and I'd like to offer a special welcome to staff from ONDCP here with us today and thank all of you for your support. In addition, we are joined by representatives from LAPA who have led this project on behalf of ONDCP. So a very special welcome to Sarah Kelsey, Susan Weinstein, and John Woodruff from the LAPA team. The LAPA team will be engaging in the chat, answering questions, and sharing relevant resources throughout the discussion today. Just a little bit of housekeeping before we get started. All attendees are muted, but we can interact with you through the Q&A box in your Zoom control panel. If you have any logistical questions, please feel free to direct chat me in the chat box, and I can help you out. During our discussion today, we will hear from experts on treatment in emergency department settings efforts. Thank you for sharing your questions during the registration process. We have shared those with the speakers, and hopefully we'll be addressing these throughout the conversation. In addition, we encourage you to ask questions in the Q&A box, and we will get to them at the end of the conversation today. We will also be posting relevant resources in the chat box throughout the discussion. This session will be recorded and will be made available on the Knowledge Lab website, on LAPA's website in a few short days. Now I'd like to introduce our expert moderator today, Shelley Wiseman. Shelley is the project director of the Addiction and Public Policy Initiative at the O'Neill Institute and an adjunct professor of law at Georgetown University Law Center, where she introduced and teaches a course on addiction and mental health law and policy. She is a human rights lawyer whose areas of interest include advancing public policy related to addiction, mental health, and disabilities. At O'Neill, she works on a project portfolio that's focused on the overdose epidemic and how the laws can promote access to treatment and support recovery. Ms. Wiseman, welcome.
Thanks so much, Becky, and wonderful to be here. And thank you for inviting me. I'm extremely excited to talk about this issue, this model law, and have a conversation with our fabulous panel today. I'm going to give some opening remarks and context and go over some of the highlights of the model law, and then we'll start the discussion with our expert panel. So about 15,000 Americans seek emergency department care for an overdose every week in the United States. 15,000 every week in the US. And many more people seek help for other drug and alcohol related emergencies. The numbers are growing. Fentanyl related visits are growing at the fastest rate. And these are folks that are more likely to experience subsequent overdoses and have a greater risk of mortality following discharge from the emergency department. So that's what the research tells us, that even though there are people that go to the emergency department for help, those are the people that are more likely to experience an overdose and death following that visit. One study pretty recently found that the fatality rate for patients discharged following a substance use related emergency in the emergency room from a visit were 6 times higher than any other patient going to the emergency department for any other issue to die following that visit. So that's pretty startling research there, that if someone goes to the ED for a substance use related emergency versus someone who goes for any other reason, that person that goes for a substance use related emergency has a 6 times more likelihood of death following that visit. Conversely, 78% of patients, so that's almost 4 out of every 5 people who went to the emergency department and were offered access to emergency department initiation of substance use disorder treatment and coordinated follow-up care, had significantly reduced illicit opioid use following their discharge, and reduction in mortality. And this illicit opioid use reduction declined from nearly 6 days a week to 1 day a week. So we can see from the research that the emergency department is really one place where people can be engaged following a crisis, such as an overdose, or when they're ready to accept help. And that type of engagement leads to very positive outcomes. And the lack of that engagement can lead to death for many people. Despite these statistics, many hospitals don't have a policy or practice of beginning treatment in the emergency department, and many don't have systems in place that connect people to follow up care or engage people in follow up care. Research indicates also that fewer than half of the physicians in emergency departments feel prepared to deliver evidence based substance use disorder treatment, determine what level of care somebody needs, or connect patients with outpatient treatment. So that's a high level overview of what the research says in this area. And of course, beyond the research, there is much anecdotal personal experience of people who are struggling with chaotic alcohol and substance use, their friends and families, many people who are in a place of desperation, of needing help right away, right then and there. They can't wait on a waiting list for months for a treatment bed to open up or a slot to open up, and they go to the hospital as a last resort. And many are often turned away or told they need to be intoxicated in order to get admitted, or at best, maybe given a list treated and given a list of numbers to call, or at worst, treated very poorly. Meanwhile, over the last few years, we've seen some incredible innovation in this space around the country of physicians and others who have set up shop in a tiny room in the emergency department where they work and starting to induce people with buprenorphine, provide other types of care and treatment and follow up to wildly positive results. And in some cases, those small, tiny initiatives have grown to statewide initiatives and implementation with some wonderful outcomes. And that's where the idea from this model law and laws that have been passed in some states come from, that the research is pretty clear. The ED is a place where if the right intervention is provided, it can make a huge impact. And legislation could support and accelerate the good work that's already being done around the country and save more lives. And in the model law that we're talking through today, there are three kind of buckets, and I'm going to go into each briefly. One is a framework and requirements on hospitals. Two is affirmative requirements on states, on state government. And the third is funding mechanisms. So requirements for hospitals, requirements for states, and funding. And after a review of the research and collaboration with many experts, including the folks on this call and many others, the model law that was developed was really meant to be a comprehensive template for states to build their own legislation that makes sense in light of their systems that they have, their stakeholders, their other initiatives, and their funding. So just some high-level details. I'm not going to read the model law to everybody, but some things just to make clear that are in there. So requirements on hospitals. And I want to say we went back and forth with the group about whether this should be a mandate at all. And I think we're going to get into this with some of our panelists about that. And this template model law does have a mandate on hospitals to do some specific things. There was another avenue to go, which could have been incentives or encouragement. But the group as a whole, not everybody, but the group as a whole, I think felt that there needed to be some pretty strong, both carrots and sticks in order for this to move forward. The requirements on hospitals outlined in the law include, these are hospitals or freestanding emergency departments. So I'll say hospitals, but it also includes freestanding ED. So it requires them to offer initiation of treatment with buprenorphine or methadone for patients with opioid use disorder when they present with a substance or drug-related emergency into the emergency department, or initiation of treatment with other medications, which could be naltrexone for alcohol use disorder, for example. But the right clinically indicated treatment to offer it. It requires hospitals to offer comprehensive discharge planning, a timely virtual or in-person appointment with a substance use disorder treatment provider. That is the level of care that person needs. For patients with opioid use disorder, a supply of buprenorphine or methadone in accordance with federal law that would last until the patient's appointment with a treatment provider or until a medication plan can be implemented. An affirmative connection to peer support professional that could be in person or virtually before the patient is discharged. Facilitation of transportation to that scheduled appointment with a substance use treatment provider, either by the peer support professional or other means. Naloxone in hand, referral to a harm reduction services provider, referral to a mental health provider if clinically indicated. It requires hospitals to develop a checklist and standardized protocols to implement this, and requires hospitals to have formal agreements, the range of substance use treatment providers that encompass all levels of care for connecting patients to appointments, continuous quality improvement planning, and certain reporting requirements. Now, there's more detail in the law, but it's really a robust set of requirements on hospitals meant to really shift the way these services are delivered. And then we have a similarly robust set of requirements on the state that states facilitate this process by requiring and incentivizing participation of those community-based treatment providers that are going to be on the receiving end of those referrals to make sure that happens on the community provider end. And it requires states to develop and support a network of providers that provide low threshold treatment to patients, including buprenorphine initiation and short or long-term prescribing of buprenorphine. One of the things we heard a lot during our discussions was there's just not the sufficient treatment in the community. And so that is one of the things that this law would require. It also requires the state to have a process for systemic identification and removal of regulatory barriers that are in the way of services being delivered in a timely way and paid for appropriately. And it also requires the state to add incentives for that type of low threshold treatment and timely delivery of services. One other thing I want to point out is it requires the state to develop an ombudsman program that would assist patients to navigate challenges with individual hospitals to receive care and ensure compliance with the law. The third piece has to do with funding. This model law would require adequate funding established through state grants to support initial and ongoing programming, and requires updating of the state's Medicaid framework, as well as the regulatory framework under the state insurance law. So we're talking about Medicaid providers as well as commercial insurance. Sorry, Medicaid managed care organizations, for example, or straight Medicaid, and commercial insurance providers that they would have to ensure reimbursement for the services provided under this initiative and all the different providers that would be on the receiving end of the referrals. And there's also a prohibition on utilization management, including prior authorization for the services outlined in the bill. So I know that's a lot. I didn't put together slides because you can see for yourself in the model law, but the thing to remember is it's the three buckets: robust set of requirements on hospitals, a set of requirements on the state, and then making sure that we're funded appropriately. So I'm excited to jump in to some discussion with our esteemed panel. I'm going to give a few introductions and then we'll get into it. Dr. Eric Ketchum is board certified physician in both emergency medicine and addiction medicine. He works as an emergency medicine physician in Santa Fe and in Espanola, New Mexico, for the Presbyterian healthcare system. He works clinically as an addiction specialist at Presbyterian Espanola Hospital, where he sees patients in an SUD clinic, and as an addiction medicine consultant. He also serves as the medical director for a medical detox and residential treatment center, Centacor Foundation, and served as the medical director of a methadone clinic and opioid treatment program for nearly 8 years. Dr. Edwin Chapman has practiced in the Washington, D.C. area for over 47 years and specializes in internal medicine and addiction medicine. Over the past 21 years, he has investigated the complex mix of addiction, untreated mental illness, infectious diseases, criminal behavior, and chronic diseases in which patients have 20 to 25 years shorter life expectancies. Dr. Chapman is a founding member and secretary of the board of directors of the Leadership Council for Healthy Communities, where he is bringing integrated medical care into underserved communities and faith institutions. Justine Waldman is board certified in addiction medicine, emergency physician, and a fellow of the American College of Emergency Physicians. Since December 2016, she has been providing low threshold medications for addiction treatment, hepatitis C treatment, and acute care to people who use drugs at the Syringe Services Program at the Southern Tier AIDS Program in Ithaca, New York. She's currently the CEO and CMO of Reach Medical in Ithaca, which opened in February of 2018. And last but not least, Brandon George is currently vice president at Ascension Recovery Services. Prior to joining Ascension, Brandon served as the vice president for recovery and advocacy programs for Mental Health America, Indiana, and the director of the Indiana Addiction Issues Coalition, which advocates for recovery through public policy and education. Brandon is consulted throughout the country on both policy and recovery infrastructure. And I will say this, knowing each of these panelists personally, some very well, these little bios do not do justice to innovation, passion, and just what incredible humans each of these panelists are, I have to say. And I'm really excited to have this conversation today. We'll start with a question for Dr. Ketchum. We described in this model law a pretty big shift, I would say, for a lot of states and a lot of hospitals. What types of interventions or approaches can support system-wide adoption of this type of shift that we're looking to make, and in emergency departments specifically? And can you also talk about your experiences on this topic in New Mexico?
I'd like to answer the second question first. I've been introducing or initiating buprenorphine in the emergency department for about 12 years or so before there was really any significant research done on it. I never really felt this need to be researched. Do we need to research initiating insulin in the emergency department? There's a whole lot of other things like starting somebody an antihypertensive, giving somebody albuterol. It's not like we had to research that we should prescribe those things from the emergency department. Didn't make any sense. And granted, and I really appreciate my colleagues who are researchers who do continue to study after study to demonstrate the value of this. But in New Mexico, I've had some experience that have been very rewarding, and I've been really thrilled to see some hospitals really just waiting for somebody to come along with expertise and experience doing this to help them get the ball rolling. That's been the experience with the organization I work, for example, and we were able to launch several of the hospitals in the Presbyterian system, but they were hungry for it. They could see the need. They had already really didn't have a lot of stigma. They were always trying to figure out how do we overcome the different barriers. And granted, all the adoption is not 100%, but the adoption steadily grew once we started doing it, once we really educated the physicians, once we educated the nursing staff, which is just as critical. They spend a lot more time with the patients than the providers do. So it's really important to educate the nursing staff and reduce stigma there. And just getting the support of hospital administration, working with pharmacy, making sure all the little barriers are down, that the medication is in the emergency department. It's got to be in the Pyxis. You got to build it into the order set. You got to make it as simple to use as possible. You want to make it so you put up basic flow diagrams so everybody understands this isn't really complicated. I just have to understand a few history items I got to get from the patient, which is a lot more valuable than getting urine drug screens, usually. And so you can start this medication. You can do it successfully. And that we should be prescribing, just like we would prescribe 30 days worth of an antihypertensive, we should be prescribing 30 days worth of buprenorphine. We shouldn't be limiting people to 2 days of medication because it's a controlled substance. There's a whole lot of these barriers that we continue to encounter as people perceive as policy, but it's not really policy, right? It's often just a cover for the stigma rules we create. That's the one thing I will add on to that is as providers start to have some success and some of the nursing staff has success and they see how well patients respond and they see particularly acute withdrawal resolve with buprenorphine, they really share that with each other. And it really takes just a few tastes of success, a couple of patients that go well to really spread the word. The other thing that really helps is internally when like I see patients in clinic and follow up, if I send that email to that provider and that nurse that took care of the patient and said, by the way, Joe X was still following up in clinic. They're doing great. You've really helped save this patient's life. Those things really make a difference. But so I've had that kind of experience. We've also had the experience with what I do for the New Mexico Bridge program, which is where we work with hospitals in the state. So that's a SOAR grant funded project. And most of the folks come from the University of New Mexico. I come from the Presbyterian system. I serve as the lead physician educator and also what we call the director of clinical implementation. So I'm the guy that meets with the hospital and goes over all the nuts and bolts, going over the EMR, working with the pharmacist, getting into the Pyxis, developing just those education diagrams, and how do we get things off the ground to make them happen. But some hospitals, just like the Presbyterian system where I work, were just hungry for that, just waiting for somebody to step in to show them how it's done, and really have taken off. But it really requires, for that to be successful, you have to have that physician champion, and you have to have just a critical mass of people who believe in this, that have heard of it, or maybe they did it someplace else. And the same thing with the nursing staff. If you have a leader that really is obstructive, which happens in some places, or just adamant that we're not going to do this, if the obstruction comes from the C-suite, sometimes the CEO doesn't want to hear about this. I once had a CEO at a hospital tell me, Dr. Ketchum, if we start doing this, then we're just going to have more of those patients come here. And I said to her, yes. And wouldn't it be a wonderful thing? And imagine if all those other lives we could save. But the truth is you get people to treatment and then the visits, the repeat visits really go down. And you can demonstrate that. We've got so many research studies showing that you get people to treatment. Actually, they don't come to the emergency department very often after that. And if they do, the hell they know how to get help. But those are really the barriers. We've sometimes invested a lot of work into a particular hospital. They've really flown afterwards, have done great. And we've also invested where we just really didn't get that champion to buy in, whether it was pharmacy that was putting up barriers. That's happened sometimes. The C-suite, sometimes a nursing leader was really obstructive, doesn't want the nurses to get educated. But particularly the most difficult, if you can't get that physician champion, then it's just really hard to get that off the ground. So that resistance from physicians, it's usually the same thing. It's wrapped up in stigma, wrapped up in just belief that, or the stated fear that your hospital is going to be overrun with patients seeking treatment and you won't be able to handle it, it's never been demonstrated. It always pans out to be the opposite. But so what does it take? I would love to believe that if I could just actually devote my whole life full time to traveling around educating hospitals, and if our nurse educator could do this full time, that we can continue to get every hospital on board. But unfortunately, I do believe that as much as some hospitals are just waiting for the expertise to show them how to do it, there are a number of hospitals that are going to need more carrots and more sticks. They're going to need that incentive from CMS that affects reimbursement. And they'll also need to believe that there are legal ramifications for not doing so. And unfortunately, I hate to believe this, but I think that if we can't get effective legislation to help move these things along, such as your group has written and proposed, it may take the Libby Zion case of opioid overdose, right? Some otherwise young, healthy, promising college student comes in after an overdose, doesn't get any offer to treatment, has what we know happens all too often, and then they die of an overdose a few weeks later. And that becomes the landmark lawsuit. And I hope it doesn't have to happen that way, but I'm afraid that it will if there isn't effective legislation that's able to move this.
Thank you, Dr. Ketchum. Yep, I hope not either. We'll move on to Dr. Waldman. As I mentioned, there was a lot of back and forth about whether this law should include a mandate on hospitals. Can you share your thoughts on whether hospitals should be required to provide medications for opioid use disorder in emergency departments specifically, but also the range of other items that we talked about? And I know Dr. Ketchum touched on this too. And what are the elements that really are needed to make this happen from a legislative standpoint?
Yeah, I haven't worked I had a long history of being an emergency medicine attending, but I opened a medical practice doing low threshold harm reduction and buprenorphine years ago. But what I know about the emergency department is that it's a hard job and you're basically running around like a maniac doing things as fast as possible. And it's, to me, a bit obscene that CMS hasn't made this a criteria like they make many other criterias for hospitals in the emergency department. And examples of those are an aspirin. If someone comes in with chest pain, they all get an aspirin. If someone has stroke symptoms, they all have to get seen within 10 minutes. If someone a few years ago, the new one, or it's probably 10 years now, if your heart rate was high, you had to get an antibiotic. And some of them have been relatively hard to follow because the rules don't match. But the issue is that you have to get, in order for hospitals to put priority on this, they essentially, it feels as though they have to get negatively punished by the government. And then if they get negatively punished, then all of the rules follow. If a hospital knows, oh crap, starting Q1 of 2024, we need to have this happen on every single patient, then they will change the electronic medical record as fast as possible. They will put it in every single patient's chart who comes in with a certain diagnosis, and it will be a click box for the provider. They will make sure that all of the PICSs, which are like where medications are held, are filled. They will do everything and make it happen. But the only way that will happen is when the government sees this as an important element to have as part of emergency care, which it feels as though the federal government or CMS hasn't really deemed this to be the most important thing, but which feels a bit ridiculous to me. The one thing that, and it sounds like Dr. Ketchum has had really great success, but I feel like outreach of an emergency department is a bit of a coin toss at best in a lot of situations. So there's a sort of printed thing that you give out to patients that says, follow up with these providers in 3 days. You call the office as a patient and they're like, I don't know why they told you that. We can't follow up. So it's hard for emergency departments to keep track of providers who are seeing patients and who aren't seeing patients. And that feels to me it would end up being like a 3 or a 4-hour a week job for someone to make sure that all of the follow-ups stay accurate, which is actually completely appropriate, but it would take a lot of upkeep to make sure that stays in place because I think it's hard to make that happen for most patients in the emergency department, depending on the setting, of course. But I don't know if a law would really help that because all you have to do in the emergency department is type go see blah 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 in 4 days. That doesn't really equal like a warm handoff. And a warm handoff is hard to accomplish out of an emergency department unless you could do some direct scheduling, things like that. And I really agree with Dr. Ketchum that this making the you really patients need a 1-month script so that they have time to follow up. A lot of patients don't recall what happened in the emergency department at all because they're overwhelmed and traumatized by the experience. That's the other thing that's a big deal is emergency physicians don't want the patients to come. The directors are like, they'll all come. But the fact is that people feel stigmatized in the emergency room. They're not running there. They're only going there when they're completely desperate because they know they're going to get stigmatized. And I think many emergency departments don't even know that. And okay, one more thing and then I'll be done, which is it's not even, I don't believe it's fully mandated that when a small ER or suburban rural, not every patient leaves with naloxone, right? So even the buprenorphine is one thing, but getting naloxone to every patient would be amazing. And this wouldn't happen with any other disease. That's I feel like every other disease that has a death or a fatality rate like this one gets treated by CMS as being super important. And this isn't feeling that way.
That's really great insight, Dr. Waldman. It's a combination of even if a mandate is there, it's wouldn't be enough, right? There's deep rooted.
They'll do a lot for a mandate.
Yeah.
A mandate will force things. That's like it doesn't matter what the mandate is. The hospitals do not want to lose money.
Yep. So it's the start.
Money thing is huge for hospital systems right now. They can't lose money. And so if they know that they will lose money if they tend to if a patient leaves without naloxone, they will make it happen. That's how you make things happen, unfortunately.
So I see we have Dr. Chapman back on Hope, and I'm going to combine a couple questions for you. The question before was about stigma and about how we're talking about patients who might have already a mistrust of the healthcare system who've been treated poorly in the past? And what can we do to shift that as a culture shift in these settings? And I'll combine that with the question of just in general, how do we help address the resistance, the hospital resistance and provider resistance to doing this type of thing? Dr. Waldman talked about it a bit, and Dr. Ketchum did as well. And not just about providing the treatment, but also the additional lift that it would take to really ensure that people are connected to the next level of care. For example, helping with the transportation element.
I think the beauty, what we learned from COVID and the implementation, the forced implementation of telehealth really changed things dramatically. And I think that we can use those lessons to really connect people like peer support specialists to emergency rooms in a just-in-time manner. And the same thing with providers. The American Society of Addiction Medicine had a project back in 2018 called the Patient-Centered Opioid Addiction Treatment. It was never adopted, but it was the understanding that we do have a core group of physicians who are well-versed in opioid treatment and substance abuse treatment that could be used as mentors, and they're all over the country. So if we were to match that based on the geographics and demographics of our various locations, particularly if we look at a rural area where you have a hospital, but you don't have the ability to afford to, say, pay a peer support specialist to be on staff or a addiction specialist to be on staff. If you use telehealth to supplement those services, you could really get high level treatment and get past the stigma that providers have. So we really have a problem within our own profession in that they're actually providers who are afraid because they haven't been in this space before. And I just had that experience over the weekend, again, showing how telehealth close those gaps. Give you a classic example. In Maryland, Dr. Eric Weingart, who is the chair of psychiatry at the University of Maryland and runs the what's called MACS, the Maryland Addiction Consultation Service, did a pilot demonstration with one of the remote jails where the University of Maryland is providing those types of services, medication-assisted treatment in the jail. So if we transition that same model to an emergency room, we just had a report that came out from Ohio and Kentucky showing the dramatic increase in medication-assisted treatment with the telehealth during COVID. And there was a tremendous uptick in patients started on medicine using telehealth. I think if we continue to push to have telehealth extended indefinitely, as well as connecting peer support and specialists to remote areas or to any hospital or emergency room that is presently not using it, we could use that as a mentoring device to get more people involved. And of course, we have to have the medication at those particular remote locations, and that should not be a problem, particularly with buprenorphine. And you have to match it again with where they're going to follow up. What are the services that particular patient, once we get their specific demographics, what's close by to them? What kind of pharmacies, whether they're methadone clinics anywhere in their vicinity would determine which of the medications they would be started on. But I think telehealth is going to be the key.
Thank you. There's so many questions I want to ask everybody. I have a few questions for Brandon, but I just wanted quickly to piggyback off of what you were talking about, Dr. Chapman, and direct a question to Dr. Waldman about using technology or other types of innovative methods to do this type of connection of patients. And Are you seeing any of that in your work in New York? Are there lessons learned that people could be interested in hearing about?
I feel like you're like telepathically connecting with me. I was like, pick me. Um, yes, I started a low threshold medical practice with buprenorphine and primary care in 2018. And just by word of mouth, because we partnered with syringe service programs. And at that point, really, it's either you're cool or you're not cool. So if you're cool, then everyone tells everybody. And within a year, we had 1,250 patients in 21 counties in New York. And then because we're small and nimble with COVID, we quickly gave everyone 2 or 3 months because we could tell this is going to go crazy. And then we switched all over to telemed. And now we're in 56 counties in New York with between, I would say at this point, 6,000 patients. And all of that is word of mouth or connecting with syringe service programs. And the studies are remarkable. The DEA may not believe the studies are remarkable, but the studies are remarkable. And what's even more remarkable is that telephonic is amazing because we did a small study on telephonic, and the folks who use telephonics are the folks who aren't going to be able to get anywhere. Transportation issues, issues with employment, issues with housing. And so you really feel like you're helping somebody who just really wouldn't even go out there. And what's interesting for me is I think as providers know that it seems as though the older population has a lot of trouble with the videos. And so they want to get on the video, but they can't. They're so apologetic the first time. And these often are like VA patients who at that time couldn't get buprenorphine, aren't going to tell anyone, are not going to go to rehab. But the idea that they could say it on a phone, get medication, it's really remarkable. And we get about 30 to 50 calls a day to start patients.
Awesome. Dr. Chapman wanted to add something, and then I'm going to ask a few questions of Brandon.
Yes, I think the pushback that we always had with these medications, methadone and buprenorphine, was the fear of diversion. And that's the second lesson that we learned from COVID. The HHS Inspector General released a report, I believe in May, that showed that diversion of methadone and buprenorphine was only 2%, and there was no change during COVID. So again, it's these types of lessons were good things that came out of COVID because it really showed us that we were being overly restrictive and really creating barriers for patients rather than removing barriers. So I think that's going to segue into our conversations about methadone reform so that patients don't have to go to the clinic every day. That frees them up with the ability to work and childcare. It changes the whole paradigm.
Absolutely. I'm going to shift to Brandon to ask. So, one of the things when we were really engaging with folks, again, with folks who had been to the hospital following an overdose and were sharing their experience with us, one thing that they universally agreed on is that it's a completely different experience when they're engaged by a person who has walked the road in their shoes following an incident like an overdose or a time when they might be receptive or whatever it is, that they had been so demoralized by the way that they've been treated by healthcare providers or by the healthcare system over the years, that talking to somebody who was a peer really made all the difference in the world. And people universally felt that peer support had to be an element of this if it was going to be a success. And they didn't even talk about wanting a peer only following an adverse event, that anyone that's has a substance use disorder, that whenever they have to engage the healthcare system, that a peer would be helpful because they have felt stigmatized because it's in their record, even if it was 5 years earlier, 10 years earlier. Can you talk about, and there were some questions in the chat about peer support as well. Can you talk about that element, what you've seen, why it's so important, even though it's a huge departure from the way things are done in hospitals often?
Absolutely. Thank you, Shelley. And really just in general, appreciate both the work done by LAPA and the panelists on here talking about this topic and the value that's given both when you guys were creating the model law to peer support, people with lived experience, both in the creation of it and then ultimately what was put forward. There's really good data now on the impact of peers within hospital settings and ED settings, but you really don't need to look any further than some of those interviews that Shelley was talking about. People are historically criminalized within both our systems. And so there's enormous fear when people overdose. Usually it's around arrest or what's going to happen to them as a result of their overdose by simply using illicit drugs. They are desperately want to get out of the emergency department because of those things. And so having somebody, a peer support who is trained and has lived experience and the ability to not only identify that person, but build trust with that person. Oftentimes, what may take other people months or years to do, building trust wise, can happen in a matter of moments with peer supports. That's the first part. And that's the very first piece of the puzzle. And then something that was mentioned earlier to me is the second, being human resource broker in that space. Even with the initiation of buprenorphine, a lot of times when people don't have anywhere to stay that night, their safety is in jeopardy. They don't have a physical safe space to stay that night or transportation somewhere or some of those other like Maslow's hierarchy of needs taken care of. They can't, like the idea of getting to a pharmacy the next day or 2 days later or being able to pay for it, those things are still down the priority list. And so having a peer support that can help obtain and get somebody connected with those things. I think it was mentioned earlier, like warm handoffs are hard just in general. They're even harder within a hospital setting. Usually all we see is, right, here's the piece of paper, here's the resources. And anybody that's navigated SUD treatment knows how broken it is. I used to call it a broken system. And one of our friends, Jay Chaudhry, said, is it really a system if it's broken? And the answer to that is no. And so anyways, somebody that's almost just died, that was intoxicated from that overdose experience, the ability, certainly for me to navigate that experience. And I'm super familiar with the space and help build some of it. And so having a peer to walk with them throughout and get those connections is really important. And so building trust, number one, the other resources that are desperately needed outside of just the medication piece is another. And then I think we referenced it in the model law. Dr. Brad Ray, Dr. Watson did a study in Indiana from ED peers and medication in the emergency department in Indiana. And the difference of follow-ups, filling prescriptions and follow-up visits when peers were involved were much greater. And so it really, again, we don't need the data to know that it works, but we have it because it certainly does.
Thank you. I wanted to ask a little bit also piggybacking off what Dr. Chapman said about being able to do kind of physician to physician support or learning. There are a lot of different models out there. There are echo models and other things. And I know Dr. Ketchum, I think you've been involved in some of this type of training. What are some of the best practices with technical assistance or support that you've seen be successful in emergency departments who are really trying to get this right? And I also want to note that you made a comment in the chat about culture change in general, and you can't legislate a culture change, but you can put the building blocks in place to encourage it or enable it to happen. So what are some things that you have seen be successful or that you think could help move the dial?
In addition to what I just said earlier about trying to make this as simple as possible, right? To try to put every piece in place so that the provider, the physician, the nurses working, they don't have to think about it too much, right? But secondly, is having somebody they can call, right? So I don't get called all the time. Now I only get called with more complex patients, and I'm used to my emergency departments where I work in calling me frequently. And I was thrilled that they were calling me because that showed that the providers and the staff were engaged in wanting to help patients. So helping them through a few cases, and then they become more dependent, and then they help each other. And then they call me with just the more tougher cases. And that's what we tried to create statewide through the New Mexico Poison Control Center in our collaboration with the New Mexico Bridge. I and 2 other emergency physicians who are also addiction specialists, we take call 24/7. The poison center is covered, but So that's good kind of for a statewide support effort. But the other things that really have made a difference as far as a cultural intervention, I work in a hospital where I do most of my addiction work, where right now, in fact, this week, we have an addiction nurse specialist educator who is spending a total of 24 hours this week. We're running 6 4-hour workshop sessions working with the staff. And the expectation of the CNO is that every nurse will join one of these 4-hour sessions. And these are very interactive sessions. And they're really all focused on educating the nursing staff about substance use disorders, understanding that they can understand that the neurobiology and the fundamental neurobiology behind it, some of the fundamentals of pharmacology, but also to really break down the barriers of stigma. Because in my experience, that if the nursing staff really buys into this, and when they learn to communicate with the patients differently, that they really can move the providers along. When I started doing this in the emergency department 12 years ago, when I was the medical director of the ED, and I was trying to solve a local problem. We just built the order set. We started using buprenorphine. But once the nurses saw how much easier this made their job, in other words, they could treat acute withdrawal. Now, granted, it was a little easier then. We were mostly dealing with heroin and oxycodone, not fentanyl, which is a little more challenging. But in any case, once they could see the difference this was making, how much easier it made to manage patients in opioid withdrawal, then they were the ones who really started coercing the other physicians. They were saying, you can do this. We can start an IV. We can go through all these medicines if you want. Or you can just give this patient some ondansetron and then some buprenorphine, and this will be a lot easier. And so then all the physicians started getting on board in a lot of ways because the nurses pulled them to do it. So, but that kind of institutional investment is really important. And it also requires that all the physician leaders and the hospital leaders set that example, that this is something, the stories they want to share about the impact we've made with certain patients and how well these situations were handled. But it's not just investing in how to communicate, it's working with security so that every time we search a patient, that we do this in a scripted way so that we make sure the patient understands we're doing this for your safety. We do this for all patients. And we are going to, at the same time, providing that reassurance, we will treat your withdrawal. You will not suffer. We're going to help you through this. And if they hear that enough and people believe them, it really makes a difference. So you can invest in it, but it requires investment. It requires education. It requires setting that example, expecting that example to be set. But you would do this like we did many years ago. Like if you're wanting to get a better Press-Ganey score, right? The problem is we didn't necessarily invest in improving the Press-Ganey score for patients with substance use disorders because we figured they're probably not going to answer a survey anyway, right? But hospitals have worked really hard to improve that Press-Ganey score, did a whole lot of AIDIT training on how to talk to patients about other things and making sure their needs were met. If they can do it there, they can do it for this.
Excellent. Dr. Chapman had something to add. Then I'm going to ask Brandon another question. After that, I'll turn it back over to Becky to get to questions in the Q&A. So if you have questions, put them in there and we'll get to them in the next segment. Dr. Chapman, please.
Yes, I actually have peer support using telehealth in my office. One of my patients in recovery and his wife, who was not involved in substance use disorder, but lived through his history, we were able to get a grant through the Leadership Council for Healthy Communities, the faith-based that I work with, from SAMHSA. And they are paid on this grant and actually do what I call reverse telehealth. They're actually at home. And when one of my patients comes in that has a housing problem or an insurance problem, we can put that patient in an exam room and connect them to the peer support who's actually at home. And once they make that connection, the comfort level is such that we don't get those calls anymore. Those calls then become direct calls to the peer support specialist, and it really takes the burden off the office. And I think that's really what has saved us in terms of not getting burnout. Peer support is tremendous.
Shelley, one thing I'd chime in and I appreciate, I think that Dr. Chapman, you're right. And this idea of being able to help we're all short staffed. Nurses are short, like there's workforce shortages everywhere. And peers help other professionals work to the top of their license, right? And so that, to your point, you don't have a nurse or a physician trying to connect some of these really critical pieces. A peer support can do that and allow folks to continue what they, do best and maybe is more in line with what their daily activities should be, despite the fact I'm trying to be helpful. So sorry, Shelley, go ahead.
No, that's great insight. I did want to ask you a question, Brandon. I know after this model law was developed, you worked on an effort to try to get a law implemented in Indiana. And can you share a little bit about that experience and a state like Indiana, which has probably many competing priorities and different perspectives? And how did that experience go? And what advice do you have to those listening in who are thinking, hey, we really need to get things moving in our state?
Yeah, I appreciate that. And so the timing of this worked out well legislatively in Indiana. This was wrapping up towards the end of the year, and our session runs January through May. I think part of what is probably not in my bio is a registered lobbyist in Indiana for 5 years and was part of my primary job duties for the past 5 years. And when we started talking about mental health, SUD, behavioral health priorities for the upcoming year, this was talked about during Behavioral Health Commission and started looking into some data, and it's been alluded to, but we start looking at all of the overdose deaths in Indiana. Over 50% of them had been to an emergency department in the prior 90 days of the people that actually passed away and died, fatal overdoses. So we have all these conversations of how do we get to people, and they're coming to us. We have them. They're in our emergency departments. We touch them, and then they don't get the evidence-based treatments we're talking about. And a lot of them, unfortunately, end up overdosing again. And that was a very compelling conversation point. It was just in everybody's face that, okay, we are seeing these people and we don't have the infrastructure in place to be able to support it. And we were able to help draft a bill, House Bill 1462 in Indiana last year, and got the support of the governor's office and a variety of stakeholders to use the framework of this model law as the way to create it. And just briefly, what we did out of that is we were essentially going to have all the hospitals, emergency departments in Indiana create how they were going to respond, essentially a plan, a strategy for doing brief interventions, initiating medication, initiating or connecting SUD patients to treatment, naloxone, peer support, and all the approved FDA medications for alcohol and substance use disorders. And there's a lot of competing issues here. It was talked about. The big thing from the hospital association was there's not the proper infrastructure. We lack services in our community. So putting the burden on us when we don't have the appropriate resources in the community turned out to be a real issue. And there were some real dead zones in the state where there wasn't proper treatment to be able to get people. The financing attached to it, Shelley talked about the Medicaid burden or how it's written and that it has to be included. There was pushback from the state on being able to do that. We were able to get most folks in line. We got it out of one half of the House. We got it through the Health Committee in the other House. And it was the appropriations piece where it died on our end. And so we got about 75% of the way there. And we learned things along the way that everybody has different pain points. I also learned that making that comment about all the folks going to the emergency department and then dying is offensive for some physicians in emergency departments because it can be thought of as an attack on what they're doing or the responsibility that is being thrown around there. And I think the reality is we want to make sure that our treatment systems and we're giving evidence-based treatment at all our access points. And that includes the EDs. And we got a commitment from the Hospital Association in Indiana to work on these strategies. Even without the legislation, there was a promise essentially that we will do this. If you don't do the legislation, we know it's a priority now and you have our attention and we're going to be working on it. And I can keep everybody posted on if that actually comes to fruition or not, because it hasn't thus far. And we're 11 months into a year and I haven't had one conversation with anybody about doing anything on education on these topics. Or I want to reach out to Dr. Ketchum already and say, hey, how do we get you to Indiana to work on this? And it's complex. It's hard. There's different pain points. There's a lot that has to be taken into consideration. The money piece of it, the hospital piece, there's just training, the ongoing funding. And yeah, and we're appreciative for it. And look, Indiana is a super conservative state. There's other priorities. They don't like forcing things. They don't like forcing regulation. And I was surprised, honestly, that we got 75% of the way there on the first pass. I bet you we would get it all the way through if we went at it the next 2 sessions.
Yep. Sometimes these things take time. I do know before a law was passed in New York, this was when I was working in New York, we worked with the Greater New York Hospital Association to move things, and they were fantastic. It was, the hospital associations are just can be a tremendous partner.
Yep.
Plus the bully pulpit of the governor's office, that really helped too. And the other thing that helps is money, as Dr. Waldman said, and I know you just mentioned, and I wanted to ask, and I know we have a few audience questions. Dr. Waldman and Dr. Chapman, both of you are participate on the opioid litigation boards, Dr. Waldman in New York, Dr. Chapman in DC. Is that an avenue potentially that should be explored for the carrot in this combo? Has it? What are the things that really need funding? I don't know if those are controversial questions, so answer how you want. But is that there's a huge influx of funding? Is this something that could or should be prioritized? States are starting to spend the money. Counties are starting to spend the money.
In New York, it was chosen to, they did put a lot of money towards Matters, which is a referral program out of emergency departments. But I think I think there were lots of wins and losses with the Opiate Settlement Fund Advisory Board. There's a lot of people at the table, and there are a lot of competing interests sitting at the table. I ended up doing a lot of the writing of our report the first year. And I think the things that we were lucky to do is put in a lot of language around culture, put in a lot of language around social determinants of health, put in a lot of language around co-occurring diagnoses and making them racism, everything, making it part of the RFAs that would come out of New York. And I think that was effective. I think that was the best, but at least in New York State, the big chunk of the money went out last year, went out in 23. That was the biggest chunk. And then and I think there's more money than they thought coming, but it was something in the hundreds of millions, like 160. Don't quote me on this, but I think every year after that, we're looking at 20, which seems like a lot, but it's not really for a state. So I have some hope. I think New York is doing a lot with the Matters program, but I don't know that all the states will come together and say, we should promote this, or lots of states will focus on emergency departments. There's so much need for so many things that it's hard. I don't know what Dr. Ketchum's experience is.
I think that peer support is going to be one of the major focuses in the district, and that's been repeated over and over from the community. And I think the other thing is really looking at peer support as permanent positions. I do look at peer support now, almost the fire department or the police department, that there should be a specific number to call, that they should be salaried with living wages, retirement benefits, et cetera, because this is not a service that's going to go away. The other thing is, there was a study done in California, and there are multiple studies using cash contingency management. And I think when our peers go out and touch someone, we need to give them the tools that will get that person to come in. We know that perhaps somewhere only 1 out of 10 patients who overdose and die have actually been in treatment or MAT. And I think if we can turn that around, if we can find the incentive payments that will get these patients to come in. It's surprising in some of our research studies, $50 or $100 brings people in, and people start bringing their friends in, relatives. So I think there's a window of opportunity there using our peer support to give those types of tools.
Yeah, that's great. It's interesting what Dr. Waldman said about how the funding was for the connection part, right? Not to the hospital specifically, but about how to get people from the hospital to that next appointment, which was something that we heard was really a big concern from folks. And interesting also, Dr. Chapman talking about the peers, like building the infrastructure that can last. Dr. Ketchum, interested in your thoughts as well. And then I promise I'll turn it back over to Becky for some of the Q&A.
I couldn't agree more with the need for peer support. I've worked with a few different peers in different settings, and we have, I think, the most amazing peer support worker at our hospital. And he is in recovery about 6 years now from multiple substances. And he's like this giant teddy bear of a guy. But he talks about this when he first started working here. This is a community that has a very high rate of substance use disorders and substance use disorder related mortality. And he talks about how in this very hospital, he had been here several times for medical clearance for incarceration, for intoxication, withdrawal, other things. And he has done so much to raise up the level in the community, and patients love to communicate with them. But also by having him in the emergency department, he can see when people coming in, he can see complaints on the tracking board, and he'll just head into the room and he'll start talking to them, and he starts gathering this information. And sometimes he's calling me remotely before he's even talked to the provider in the emergency department, and just with questions, or he starts a secure chat. Once again, there's so much we can do to connect people with treatment using technology, and not just telemedicine, but just electronically. We can set up appointments for our patients. We have navigators in so many of our emergency departments. My emergency department's only about a 40,000 volume annual ED. That's a medium-sized emergency department. And we have a navigator, and his job is to connect people to treatment, to primary care, to the cardiologist, to the orthopedist, to general surgery for follow-up, et cetera. And they do the same thing with helping people get connected to substance use treatment. But the peer jumps in, he gets involved in that conversation, and instantly the provider working is so much more comfortable because they've got somebody who really is able to get the history that matters that we need. Then they'll may call me with a technical question. But peers, bringing those peers to the bedside and growing access to peers. This is a major challenge for hospitals, by the way, that needs to be addressed, because many hospitals have difficulty employing a peer. And the reason they do is because they have very strict HR requirements that make it difficult to hire somebody who's had a felony. And many of our very best peers, in fact, most of our peers have had some interaction with the criminal justice system. And so this really held up our peer support program for 6 or 8 months from getting off the ground. We had peers hired, couldn't fit through HR. And we had to go back and have these meetings to say, okay, what can we change? So finally, at least they were able to drop the problem if they had a felony as long as it wasn't a violent crime, right? So as long as they didn't assault anybody. And many of their felonies were related to using and or theft or prostitution to support their needs. Those are withdrawing. And so that was a big barrier we had to overcome. And when I consult with hospitals around the state, when we're helping guiding them through this process, talking about peers, the first day we talk about peers, we have to start talking about what it's going to take for you to hire one, and how you have to start working on the HR issue right now, because it's going to take a whole lot of meetings. At least we have models to offer them to say, this is how other hospitals have changed their HR requirements, but we need more. And there's a lot of people out there with lived experience that if we could just get them some training and make it livable wage to work in the hospital, I think we really could significantly reduce hospital readmissions as well as ED recidivism. All these things are important to the hospital financially, not to mention, obviously, improve the outcomes of our patients.
Thank you. Brandon had something, and then Becky.
Just to piggyback quickly, the hiring issue is a real issue in Indiana. There's actually something written. It's Indiana code. I didn't believe it until I saw it with my own 2 eyes. That non-licensed workers at hospitals cannot be employed if they have theft charges. There's a couple of charges, but theft is one of those. That's often, to Dr. Ketchum's point, one of those charges that people have. And so it's literally written into code. So like we had to get credentialed added in there to give protection to the peer. And so instead of trying to get it struck from code or removed, we added non-licensed or credentialed. They'd fall into that bucket, but there could be policy change needed to overcome what Dr. Ketchum's discussing.
But it can be overcome.
It absolutely can be overcome.
All right, I'm going to turn it over to Becky to get to a couple questions from the audience. Thank you, everybody.
Sure. Thanks, Shelley. And thank you, everyone. Just a couple things. One is somebody asked if this is going to be recorded, and it will. So we'll share all that information with you all. Also, just want to thank Diana Snyder, who had some great questions and comments about peers that the panelists have been engaging with in the Q&A. I did have one question I wanted to read aloud, and Dr. Ketchum, I'm going to direct this at you since you offered to answer it, and I welcome any others that want to weigh in. But from Eric Harum, I noticed the Joint Commission does not explicitly identify post-overdose standard of care or overdose prevention as one of the 7 national patient safety goals. Is there utility to compelling this Joint Commission to name overdose prevention and post-overdose initiation of buprenorphine one of the national patient safety goals? Dr. Ketchum?
Absolutely, I agree with that. Just like we ought to make it ought to be a requirement. By the way, you probably don't know this, but there's a whole lot of hospitals that don't even have buprenorphine on their formulary. And so one of the ways you fix that is you make it also a CMS requirement to have buprenorphine on the formulary. You make the FDA, or you get the FDA to list buprenorphine as a vital medication, right? Just like we have naloxone listed as a vital medication, but not buprenorphine. But yeah, some of these patient safety initiatives, which are also tied to reimbursement, right? To MIPS and other programs, it's amazing how much some of the previous standards help create the problem that we have. You may not know this, 10 years ago, even more recent than that, there was a CMS requirement, right? You got points towards your reimbursement, and it all related to time until first opioid initiated for a long bone fracture. And there was no opting out, right? So you couldn't say, I gave the patient a hematoma block, gave a nerve block, we split it, patient declined. There was no way to write decline. And children, they were allowed to get an oral opioid. So this is another case where CMS was exactly driving the problem in the exact opposite direction where we wanted to go, making it worse. But yeah, it's stunning, right? There's multiple data and studies to enforce what Shelley mentioned earlier, right? So it was a really excellent study. Just if you looked at the mortality, so looking at big STEMI centers. So somebody comes in the emergency department with an elevation MI, having a big heart attack, and it included all mortality, whether they died in the emergency department, made it to the ICU, et cetera. And in these cases, the mortality from somebody presenting with an overdose far exceeded the mortality from somebody rolling into your emergency department with an active heart attack, who might go to the cath lab and all that. And by the way, in that study, it's about 7 years old, they excluded all the people who didn't survive 3 days to walk out of the hospital, right? They already took out the highest risk patients. And even if we exclude all those people, anybody who walked out of the hospital, the mortality was much higher. This is like a no-brainer if you're really looking at how do you reduce mortality, how do you improve lives in the community, not to mention the fact that the average age of mortality is so much lower in our substance use disorder population, right? What's the number one killer in the United States now for 8 years running for patients between the ages of 20 and 50? Well, it's drug overdose. And those numbers have only doubled. I had to testify before the House Judiciary Committee 7 years ago, and I was explaining what a tragedy it is that over 50,000 people in this country died every year of drug overdose, and the numbers doubled since then. This is the obvious thing. I could rant about this all day long, but how we've built in these ridiculously complex financial incentives where we're not even addressing the diseases that are most preventable and most lethal.
Thanks, Dr. Ketchum. You want to add to that?
I feel like it's not really a great segue, but I think we haven't really gone into it all, like the racism that's built heavily into this, along with the idea of who gets hired at a hospital, who doesn't, who has a criminal charge. And I always say, I can't remember how many social determinants of health are, but I always say that the system is the last one. So you become a doctor and you think it depends on your background. You might think police are fine. You might think CPS is great. You might think like certain things are great, but you don't really, no one gives you a real education on what can happen to people when you deem that you're right about, or like the regular system doesn't necessarily help people. And lots of providers don't know that. And lots of hospitals definitely do not know that.
Thanks, Dr. Waldman. Dr. Chapman, I see your hand raised.
Yes, the District of Columbia has the second highest per capita overdose rate in the country. We're right behind West Virginia. And 85% of those overdose deaths are African Americans. And we've not yet been able to get the mayor to declare this an emergency. We got the city council to vote unanimously, and our opioid abatement commission, the majority of the people voted that this is an emergency. But again, it's cut down by political lines. And that's one of the tragedies of this whole thing, is that you have people, non-medical people, making these critical decisions. And we're going to have to take medicine back, I believe.
Thank you, Dr. Chapman. And thank you, Dr. Waldman and Dr. Ketchum as well. I appreciate that. I'm going to pass it back to Shelley for closing remarks. Shelley?
All right. So if I want to give everyone an opportunity to say a few words, there's a range of different folks listening in, from physicians to policymakers to advocates, and it'd be great to hear final thoughts from each of you. So why don't we start with Brandon?
Thanks, Shelley. And absolutely. A couple thoughts, or a couple things that I think about is emergency departments are a critical access point for all of healthcare. People usually go to primary care, urgent care, or the ED when they have issues. And we need to make sure EDs have the proper tools in place, and we find ways to support them in getting this type of stuff in place. Unfortunately, like Dr. Ketchum said earlier, I think that if left on devices, it would be a long time before it happened. And so things like this model law are probably going to be needed to expedite the process. And I think it's important to make sure that there are people with lived experience at the table. I don't think that I mentioned this earlier, not to get in the way of my other professional experience or education, but I'm a person in long-term recovery as well. And so I'm in recovery from opioid use disorder, substance use disorder, and Lap Shelley, when we were creating this law, it was vital for them to have people with lived experience at the table. And so if you do something in your state, please make sure you have somebody with lived experience at the table as well. And I certainly value that. Peer support. I'm overwhelmed at the conversation around peer support from our physicians that are on here. We talk a lot about medication and buprenorphine, but I feel like we talked about peer support as much as we did anything. And it is a really critical part of the process of people getting well. It's just really invaluable. And I appreciate from the panelists and from the folks asking questions. As always, I'm guessing LAPA and everybody else is willing to help answer questions. If there's any detail substantively about policy or what we did in Indiana on that House bill, I'm happy to connect with anybody. And I hope everybody takes this model law and helps implement something in their state based off of it. So thank you all.
Great. Dr. Waldman?
Ditto. I'm going to say one more thing. I don't think this is a shocker for anybody, but this whole epidemic is the HIV epidemic over again. And in 20 years, people will say, how could we have not taken care of people? How could we have let this happen? But I think the US has a history of doing things like this, while other countries are far ahead of the game right now. And ditto to all those things, and ditto to recognizing that opiate use disorder is a chronic relapsing disorder like diabetes. And the sooner we get our brains around that, as opposed to it being something with morality, the better.
Thank you. Dr. Chapman?
I think whether we realize it or not, we're really in the middle of a paradigm that we're actually going to change the way medicine is practiced going forward. That when we talk about peer support, we talk about social workers working with physicians, we talk about bringing the faith community into the fold, that we're really looking at what the American Medical Association has talked about, a systems approach to healthcare. And I call it community-centric care, because the lessons that we're learning are no different from a person who has diabetes or hypertension, goes to the emergency room, leaves the emergency room, but doesn't have the copay to get their medicine, or doesn't really know how to take their medicine, or maybe they have some mental health problem. We have to wrap our hands around everybody. And this is the one disease that I recognized over 10 years ago that impacts everybody. It's like trying to hold water in your hands. If you don't treat everybody, people will find a source to get drugs through the internet. You're going to have episodic criminal activity, homelessness. So this really is a disease that all of us have, so to speak. And if we approach it as a community, we're going to see the kind of results that we want. And I think it's going to force us towards universal health care, but also universal community care.
Thank you, Dr. Chapman. Very powerful. And what a wonderful way to think of it. I think that it's all of us. Dr. Ketchum?
Yeah, just a few last thoughts. We've talked about the emergency department, but the truth is that initiating treatment for substance use disorders is even easier when they're an inpatient in the acute care hospital. I can so much even better control the environment. I can really time when we start their buprenorphine. Use a lot of other adjunctive medications. I temporize people with morphine when I need to, because of its predictable pharmacokinetics. It's not very euphoria inducing, but all the same for alcohol use disorder. Alcohol use disorder actually kills more people than opioids. It kills more people than all other overdoses combined. And it's another disease that really needs to be addressed. But so many of the same machinery that we put in place, the tools we put in place of peer support and initiating medication and connecting people to treatment and to clinics, all of that, doesn't have to apply to just opioids. It's going to apply to multiple other substance use disorders, and particularly alcohol. But what we found is when we really have success, in the emergency department, that then we get the hospitalists doing this, and then the hospitalists are doing it. And we have a lot of success in labor and delivery, another incredibly important and vulnerable patient population, working with pregnant women and postpartum, of course. And we have to focus hospital wide. And the more we do this hospital wide, the more sustainable it is, right? So the more physician specialties are involved, the more nursing units that are involved. That's how you sustain it. If you really just focus on the ED and say, well, they got admitted to the hospital, we don't expect the inpatient unit to do anything about this. Just as your hospital affiliated clinics should also be engaged with this. If they're a family medicine or internal medicine or obstetrical, whatever clinics attached to the hospital, we have educated so many of our providers in our hospital clinic system. And so everybody's on board, and some people are more, more active than others, but everybody recognizes that it's something that's important that we need to engage.
Thank you. And thank you, everybody. I just have one final thought that, like Brandon, I too am someone in long-term recovery in addition to my professional life. And because of that, before I came to Georgetown, I was working in the governor's office in New York. And this was before most hospitals in the country that this was even a thought. Yale had come out with a study, and there were a few hospitals doing this. But I had a lot of friends that went to the emergency room and were told, no, you need to do this, you need to do that. This isn't what we do. And I put on a whiteboard behind my desk, hospitals treating this, on a list of things that we wanted to change. And we did. There's a law in New York now that requires this. Is it perfect? No. Is it everyone doing it everywhere? No. But it's been a sea change and a culture shift, and lives have been saved. It's just really awesome to be here today talking about this and hearing about the momentum on this and many other things. So with that, I'll turn it back over to Becky for some final logistics.
Yes.
And thank you all very much. Thank you.
Thank you all very much. Thank you for the great discussion today. We could not have asked for a more knowledgeable and thoughtful discussion. I really want to give a special thanks to Shelley and all that you did to put together this panel and support LAPA and ONDCP, and for all of you for sharing your experiences, your expertise, and your thoughts on this topic. I really appreciate the discussion. You will see I put in the chat a survey. If you're interested in providing feedback, we would love it to continue to improve this process and continue to improve the knowledge labs that we're putting on through LAPA and ONDCP. I want to thank you again to ONDCP for funding and other ways supporting this event. And thank you again to Shelley and all of our panelists. And we hope you have a wonderful day. Take care.